Hello, everybody. I hope you're having a good day. Today we're going to talk about pulmonary agents in our pharmacology class, and we're going to talk about some of the conditions that affect the respiratory system. On this lecture, we're going to talk about upper respiratory tract disorders. We're going to talk about allergic rhinitis, and we're also going to talk about the common cold. We will also discuss lower respiratory tract disorders such as asthma. I'm not going to cover COPD. I'm not going to cover emphysema. I'm not going to cover pneumonia or chronic bronchitis. And the reason I'm not going to cover all of those is because those conditions, the treatment is very similar to asthma. If I just cover asthma, I think it will do good for helping you to understand these respiratory medications and just understand that they can be used for other lower respiratory tract disorders. Let's talk about allergic rhinitis first. Remember, I'm not going to go too in depth when it comes to pathophysiology of these disorders, just because you've already had pathophysiology as a previous class. If you have further questions regarding pathophysiology, please refer back to your pathophysiology textbook. First, let's talk about allergic rhinitis. Inflammatory disorder. It is going to affect the upper airway, the lower airway, and it's also going to affect the eyes. When it comes to allergic rhinitis, there are two different forms of allergic rhinitis. There's going to be seasonal, where we also call it hay fever. Have you ever heard somebody say, oh, I have seasonal allergies, I have trouble with hay fever? A lot of times it's not people that are allergic to hay, it's just the changing of the seasons. There's different allergens that are in the air. It can be different times of the year as far as when these patients are going to have signs and symptoms. It might actually be springtime when the leaves are coming in on the trees. Some people complain more in the fall of having seasonal allergies where the leaves are changing. There might be more fungus in the air. So just remember, seasonal allergies is not just from hay that causes the allergy, but the other thing to remember, it's an allergen that is leading to the signs and symptoms. We also have people that have perennial or non-seasonal allergic responses. And what would cause this? Well, it's usually indoor allergens. Examples could be pet dander, it could be house dust mites. There's new research saying that as far as being allergic to pets, it may actually be the saliva that people are allergic to. And we do see, if there's a lot of pet hair, then the people tend to have an allergic response. And you got to think about, well, what do pets do to clean themselves? Well, they lick themselves and they use their saliva to clean themselves. So if the saliva is then getting on the hair and then the patient is coming into contact with the hair, then we see the allergic response. It's pretty interesting. A little bit more on the pathophysiology of allergic rhinitis. And remember, this is an allergic mechanism. So what exactly is happening in the body? Well, the body is going to have immunoglobulin E antibodies present. Well, how in the world do those get there? Well, the IgE antibodies are going to be generated and built up after being exposed initially to an allergen. Then the body is going to build up all these antibodies. When the patient then is re-exposed to the allergen, then the allergen is going to bind to the antibodies. Once the allergen is bound to the antibodies, it's going to stimulate the release of the whole inflammatory mechanism. And remember, we talked about the inflammatory system and all those mediators, those mechanisms in previous classes. The biggest thing to remember is for somebody to have an allergic response, it's not that initial exposure to the allergen. We need to have built up the antibodies, and then it's re-exposure where we see the signs and symptoms of the allergic response. The signs and symptoms of allergic rhinitis really come down to the pathophysiology of what's happening in the body. Remember, the symptoms are going to be triggered by being exposed to an allergen that is airborne. And now the patient is going to have antibodies binding to that allergen, and it's going to trigger this whole release in the body. So the allergens are going to bind to IgE antibodies on the mast cells. And what does that do? Well, that's going to cause the release of those inflammatory mediators such as histamine, leukotrienes, and prostaglandins. We are going to talk about these a little bit more in depth so you have an understanding of what's happening in the patient's body to cause the signs and symptoms. Histamine is going to be part of the inflammatory response in the body that we are going to see with allergic rhinitis. And remember, this is an immune response. Our immunity is going to be where the body is going to recognize a foreign object, such as an allergen in this situation, and the body is going to try to defend against that allergen in order to maintain homeostasis and maintain wellness. So what exactly is happening when the histamine is released? Remember, there's going to be damaged cells when there is an allergen, and it's going to cause a release of the chemicals, including the histamine. It's also going to include bradykinin, prostaglandins, but we're talking about histamine now. And part of this is the chemicals are going to then cause the blood vessels themselves to leak fluid into the tissue. That's going to lead to swelling. And remember, this is the body isolating that foreign substance and really trying to keep it from coming into contact with other body tissue. So histamine is going to be synthesized and stored in two types of cells, and those are going to be mast cells and basophils. And the next slide, we're going to talk about the signs and symptoms then that histamine will cause. Histamine does have two receptor sites. We have histamine 1 and histamine 2. Histamine 2, we discussed during our GI lecture. Histamine 2, once we have opening of those receptor sites and triggering of those receptor sites, we will see increased secretion of gastric acid. When it comes to the allergic response with allergic rhinitis, it's really the histamine 1 receptor that's getting turned on. And what we're seeing being released from those mast cells, the histamine then is going to cause vasodilation, it's going to cause increased capillary permeability, it's going to lead to bronchoconstriction, itching, and then an increased secretion of mucus. Again, remember, it is the body's immune system that's being triggered, and really it's recognizing that foreign object in order to try to stop that foreign object so the body will maintain wellness. This is the body's natural ability to try to fight off those allergens. But then we see the signs and symptoms of these things leading to complications for our patients where now we need to treat it with medication. Leukotrienes is another chemical that's going to be released by mast cells during the immune response or the inflammatory response. This is going to be a precursor of prostaglandin. And when it comes to what signs and symptoms does leukotrienes cause, well, it's mostly going to be responsible for those symptoms that we see in asthma. The leukotrienes are going to cause bronchoconstriction, mucus production, and airway edema. When you look at a CBC and you see on a CBC the eosinophils and the neutrophils, those do relate back to leukotrienes, just in case you were curious about that. Prostaglandins is another chemical that's going to be released during the inflammatory or immune response. And prostaglandins are also going to be stored and released by mast cells. These are going to then cause the increased capillary permeability, vasodilation, fever, and pain. Now you got to think about what we learned in the past when it comes to inflammation. What signs and symptoms do we see? Well, we can then think of redness, we can think of warmth, we can think of edema at the location. And what's causing all those? Well, now you can see the prostaglandin is what's bringing all that blood flowing to that area through that increased capillary permeability, that vasodilation, allowing the blood to come there. And then we have warmth or fever due to that increased blood flow to that location. And then it can be painful because all this fluid is going to the location. And sometimes, you know, the immune response, it is supposed to help the body. It's the body's natural ability, again, to fight foreign substances such as the allergen that we're talking about with allergic rhinitis. So inflammation, it typically is beneficial, and it's going to help to remove those offending factors, help to restore the tissue structure and physiological function with that part of the body. So then you might be thinking, well, why in the world do we want to stop all of this when we are treating allergic rhinitis if it's the body's natural ability to try to fight this disorder that's happening, this condition that the patient is experiencing? Um, so to kind of answer that question, if you're thinking, well, why do we want to use medications to treat allergic rhinitis? We need to think about too much inflammation could be the problem, where now our immune system, it is increasing that blood flow. It's really trying to fight off that foreign body, but too much is where the problem is, too much inflammation. And then that can become dangerous. Then we can actually see tissue damage. And then, of course, think about the patient having these signs and symptoms. They're probably miserable by this time. So if we can treat the inflammation, we can then help them to feel better a little bit faster. Now that we talked about the pathophysiology of what's happening in the body with the immune response and the inflammatory response, now we can take those bits and pieces and see the symptoms of allergic rhinitis. And remember, this is going to be localized to the upper respiratory system. So we're going to have a patient that is experiencing a lot of sneezing. They're going to have rhinorrhea, which is a very runny nose, pruritus, and remember that's itching. Well, where exactly are they itching? Are they itching in their lungs? No, they're not itching in their lungs. It's going to be their eyes that are actually getting itchy. Their eyes are getting watery. And remember, the sinuses are going to connect up to the eyes. And so we are seeing upper respiratory signs and symptoms moving up to the eyes at this point. And then, of course, we are having a patient that's having nasal congestion from the inflammation. Remember, all that excess blood is flowing to that location right there in the upper respiratory system, in those sinuses, in order to fight off that foreign body, the allergen in this instance. Now that you know the signs and symptoms of allergic rhinitis and a little bit more about the pathophysiology as far as what's happening in the body to lead to those signs and symptoms, now we have different classes of medications that can be used to treat the signs and symptoms of allergic rhinitis. We have glucocorticoids, and those are going to work on inflammation. We talked about inflammation leading to signs and symptoms. We also have antihistamines. Which part of the inflammation system is that? Well, it's the chemical histamine being released. Well, now we're going to block that using an antihistamine. Then we also have cromolyn, and how's that working? Well, that's actually a mast cell stabilizer. That was part of inflammation also that we talked about. And then we can also use sympathomimetics. Oh my goodness, here we go again talking about the sympathetic nervous system. Well, in this case, which part of the body is affected? Well, it's going to be the respiratory system, and we want the respiratory system to open up. We want the patient to be able to breathe, so we can use a sympathomimetic to help relieve those signs and symptoms. Notice a lot of these medications are going to be given intranasal. Why? Well, where exactly is the problem located? It's the upper respiratory system. So if we can actually put the medicine directly to that area, we're going to see better relief of those signs and symptoms. We also have some oral forms such as the antihistamines, and we're going to talk more about this in the next slides. So I just wanted you to think about these classes of drugs and think about the pathophysiology, and you can see where we're using the medications to work specifically in the pathophysiology of this condition. This picture just gives you a nice visual of the pathophysiology of inflammation, and then you can see those different classes of medications that we can use. The cromolyn, you can see it's working right there on the mast cell. We can use the corticosteroids to work on the inflammation. We can work on the histamine part by using the antihistamine. And then you can see if we're working on those different areas in the inflammatory process, we can then block and stop those signs and symptoms. The first class of medications that we'll talk about for allergic rhinitis is intranasal glucocorticoids that we can use. This is going to be the most effective drug for prevention and treatment of allergic rhinitis. You've probably heard of steroids before, and glucocorticoids, they are steroids. How do we use these steroids? Well, in high doses, we can use them to treat inflammatory disorders. We talked about glucocorticoids when we talked about musculoskeletal disorders. When we have somebody with rheumatoid arthritis, we will see the use of glucocorticoids for that. Another time when we can use glucocorticoids is to suppress the immune response in a patient that has received an organ transplant. What will happen with an organ transplant? The body will think that it's a foreign object and try to fight off that foreign object. And in this case, it's an organ that we've transplanted. So we don't want to fight off that new organ that this patient has got. So we can use the glucocorticoids to help prevent the body from killing off that organ. When it comes to allergic rhinitis and the use of glucocorticoids, we're using it for the inflammation that's leading to signs and symptoms with the congestion, with the rhinorrhea, the sneezing, etc. Well, we're using a really low dose when we are treating allergic rhinitis. Another time when we see low doses of glucocorticoids is going to be for endocrine anomalies such as adrenocortical insufficiency. We're going to talk more about that when we talk about the endocrine system. So this isn't going to be the last time you're hearing about glucocorticoids. We do have other conditions we can use the same class of medications to treat. Again, glucocorticoids are going to be used specifically to treat that inflammation. And this is really an anti-inflammatory action that is happening when we're using this type of medication. So the medications, they are going to help suppress all those major symptoms that we are going to see with allergic rhinitis. And you can see there, it's really working on all of the signs and symptoms: congestion, rhinorrhea, the runny nose, sneezing, the nasal itching, the eye itching, the erythema, which is going to be the redness right around those nasal passages. So great medication. This is why it is going to be first line treatment, because it is working on all those signs and symptoms that we are seeing with allergic rhinitis. Well, this slide got a little screwed up, but we'll manage just fine. Here are some examples of some of the intranasal glucocorticoids that we are going to use for allergic rhinitis. And you can see those examples listed there. And remember, these are going to be used in very low doses because we're giving them intranasal. We're getting it directly to the area where the signs and symptoms are located, and we're going to be able to help treat those signs and symptoms very effectively. You may have heard of some of these different medications. You may have heard of, more so probably, the Nasocort. You may have heard of Flonase. Well, why have you heard of these? Well, guess what? These are now over-the-counter medications where if we have a patient that they think they have allergic rhinitis, they no longer have to go to the doctor to get medications to treat these signs and symptoms. So they can actually just go to any pharmacy, they can buy the medications themselves, they can treat it themselves. Uh, Again, very low doses. Why exactly are these allowed to be over the counter now? Well, it's because most of the time these patients are not using these for a prolonged period of time. They really shouldn't be using steroids for a prolonged period of time. Remember, most of the time it's seasonal allergies where the patient is only having these signs and symptoms for a small amount of time throughout the year. Therefore, then they're just going to be using the medications for a small period of time. It's not going to be medication where they're taking it daily, and so we don't see so many complications. It's very nice now that the patients can just go buy these things, these medications over the counter. Now, if they need other medications, maybe the over the counter medications aren't working as effectively, there are other options. And of course, then they could go to their doctor, they would get a prescription for some of these other medications that aren't over the counter. This is a nice picture that just goes over the bioavailability of the intranasal steroids that we will see being used for allergic rhinitis. And remember, these are the glucocorticoids. You can see on the picture, remember, they're going to be given intranasal, so they're going to be going right up through that nasal cavity into the upper respiratory system, and that's where the signs and symptoms are. Remember, though, it is a medication going into the body, so eventually some of that medication is going to get to systemic circulation. It's going to end up going to the liver. Another thing is, remember, the upper respiratory system, intranasal, that is connected to the mouth, it is connected to the esophagus. So some of the medication is going to get swallowed, it's going to end up down into the GI tract, and it's going to be absorbed through the GI tract. But not a whole lot is going to end up getting to systemic circulation. For the most part, remember, there's very low doses that we are using. We're intending just to treat the signs and symptoms locally in that upper respiratory system. Therefore, we don't see a whole lot of systemic side effects, and we'll talk about that on the next slide. Here you can see the adverse effects for intranasal glucocorticoids. We don't typically see adrenal cortical suppression when we're giving the intranasal glucocorticoids for allergic rhinitis. Why? Because we are giving relatively low doses, and the patients are only using these medications for a short period of time. So we don't see the adrenal gland being suppressed where it's not releasing the cortisol naturally. What we more so see is localized side effects, such as drying of the nasal mucosa. Remember, what's happening? Well, the patient is having a runny nose when they're experiencing allergic rhinitis. Well, we're giving a medication to help dry up and clear up those extra secretions. Well, in the long run, though, we can end up drying it up too much. And now we have a patient that their nose is really dry. The good thing is preparations or medications that are aqueous, if they have fluid in them, they are going to be less drying. So we shouldn't see this a whole lot when we are giving the intranasal glucocorticoids. Another side effects that they may experience is the medication could be irritating to the throat, could be irritating to the nose itself. So we could have a patient that now is having a sore throat, they're complaining of that, or they may actually experience some nosebleeds. And again, that's all localized. It's irritation from the medication. Another class of medications that we can use, and again, it goes back to the pathophysiology with the inflammatory process. We can use antihistamines to treat allergic rhinitis. So antihistamines, they are histamine 1 receptor antagonists. These are going to be used very frequently, more frequently than the next classes of medications that we're going to talk about. These medications are going to be useful in relieving the sneezing, the rhinorrhea, and the nasal itching that we are seeing with allergic rhinitis. But remember that antihistamines are not going to work to reduce that nasal congestion. The only medication that can treat all signs and symptoms of allergic rhinitis are the glucocorticoids. Let's talk about the different examples of the antihistamines that are available for our patients for allergic rhinitis. I'm sure you have heard of one of the first generation antihistamines, the diphenhydramine. This is Benadryl, pretty common over-the-counter product. We've talked about it in past classes, so you're probably more familiar with that medication. First generation antihistamines, these are going to have the sedating side effects. This is going to be where it could be beneficial, where it's causing the patient be a little bit sleepy. But in this case, think about how they're feeling with the allergic rhinitis. They're not feeling well. They're probably not able to sleep as well as when they are feeling good and they're healthy. So the side effect isn't necessarily a problem when it comes to trying to help our patient to feel better. Uh, Non-sedating or second generation antihistamines, you can see those are going to be listed there also. The first generations, those end in mine, M-I-N-E. The second generations are going to end in zyne or dyne. You probably have also heard of some of these second generations. If you look at the trade names, the Zyrtec, Claritin, Clarinex, Allegra, Zyzol, you're probably seeing commercials for these. Plus, all of these are going to be over-the-counter medications where you could go to your local pharmacy and you'd actually be able to see these medications. Here's a nice picture going over some of the different antihistamines that we are going to talk about. Diphenhydramine, again, remember this is going to be causing or leading to sedation, making the patient sleepy. So on this slide, it just gives a nice reminder saying never drive after taking this medication. It is going to be an older drug. It's been around for a while, but it does work very well to help our patients with their signs and symptoms of allergic rhinitis. Some of the other examples are also listed on there. I don't have doxepin on my slides, but you can see that it's on here, and that one's going to be prescription only. When it comes to using the antihistamines for allergic rhinitis, they really are going to be used prophylactically in treating allergic rhinitis. What does this mean? Well, it means that we don't want the patient to start taking these medications once the signs and symptoms develop. We want them to actually be taking the medication prior to the signs and symptoms. So how are they supposed to know exactly when they're going to be experiencing complications of allergic rhinitis? Um, they may not know. They may have to take the medication for a month, 2 months prior to when they know that they're going to get the signs and symptoms. If they have trouble in the fall, they may want to start the medication like a month prior to having those signs and symptoms. There's patients that they may have signs and symptoms several times throughout the year, and they may just need to take the antihistamine regularly or daily, and they may have to take it all year long. I know my youngest son, he has trouble with allergies, and I find that I just have to give him the antihistamine year round. He takes Claritin. I give it to him every day. And I can tell you, if we miss one dose, he starts having signs and symptoms of allergic rhinitis. And one of the first signs and symptoms he has is that runny nose. It just starts pouring out, and then he's blowing his nose constantly. So antihistamine, again, they should be taken prophylactically in order to prevent the signs and symptoms. What are the side effects that we see with the antihistamines? Well, the main one with our first generation is going to be that sedation. This is where the patient ends up getting sleepy. Uh, and like I said, it's not necessarily a bad thing, especially if they're not feeling well, their nose is running, they're sneezing, they have itchy, watery eyes. You know, making them a little tired from the medication. It may actually help them to get some rest. And we all know that sleep is very important when it comes to healing. So, again, it's not necessarily a bad thing, but we do need to make sure the patients understand if the medication makes you tired, especially if we're using that first generation, the diphenhydramine, they really shouldn't be taking it when they have to be alert and attentive. It's not going to work out so well with their personal life. Other things that we can see with the first generations, we can actually see anticholinergic side effects. So anticholinergic, this is going to be where it's triggering a sympathetic response. And now we have a patient that has dry mouth. They may be experiencing constipation because we're slowing everything down, urinary retention. Again, we're seeing more side effects with our first generation medications. Our second generation, they may have some of these same side effects, but they're not nearly as common. So when you look in Nursing Central, they're not going to be underlined. They're certainly not going to be in bright red colors in there. We may see it listed as a sign and symptom or of a side effect, but it's not necessarily a common one. It is going to be common with our first generation, that diphenhydramine. We just talked about some of the PO or pill forms of antihistamines. There are two intranasal antihistamines that are also available. Again, these are working on the H1 or histamine 1 receptors, and they are going to be antagonizing or blocking those receptors. So we have Astelin and Haetanase that are going to be intranasal antihistamines. So again, they're giving the benefits of relieving the signs and symptoms of allergic rhinitis other than the nasal congestion. So we are seeing a good benefit. And again, if it's given intranasal, it's going to be going directly to where the signs and symptoms are located. Most common side effect that we do see with these intranasal, especially with the Astelin, is going to be a bitter taste in the mouth, just because it's going into the nose, the medication, and it's draining down into the back of the throat. So it is going to be the most common. Other than that, we really don't see many side effects from the intranasal antihistamines. Another class of medications that can be used for allergic rhinitis is going to be cromolyn. And in this case, we can give it intranasally. Again, it's working directly where the signs and symptoms are located. It is a very safe medication. We don't see a whole lot of side effects. The problem is it's not as effective as our antihistamine or the glucocorticoids in stopping those allergy symptoms. How exactly is the medication going to work then? Well, it is working directly on the mast cell itself, and it's going to be helping to prevent the release of histamine and those other mediators that we see in the inflammatory response. We aren't seeing the intranasal cromolyn being used nearly as often for allergic rhinitis. We are seeing it used more commonly with our asthmatic patients, and they're using it prophylactically for asthma, and it's given via inhaler for asthma. If your patient is prescribed the intranasal cromolyn for allergic rhinitis, it's not going to be helping to treat the current signs and symptoms of the allergic response. It's really not effective at treating that allergic episode. It's more useful to help prevent allergic rhinitis. So they should be using this prior to developing the signs and symptoms. Again, most effective if it's taken prior to that. So it should be administered on a regular schedule. It should be administered prior to when they know they're going to have the signs and symptoms of allergic rhinitis, and then they're going to take it throughout the whole allergy season. It does take a while for this medication to prevent the signs and symptoms. Maximal response, it may take 2 to 3 weeks to develop. So again, make sure they're taking it probably at least a month prior to when they know they have trouble with those seasonal allergies. And again, we don't see a whole lot of adverse or side effects with this medication. Sympathomimetics are also going to be used for allergic rhinitis. How exactly are these working? Well, they are going to help to reduce the nasal congestion. Thinking about pathophysiology, where exactly is it working? Well, it's actually working on the alpha-1 adrenergic receptors, and this is going to be on those nasal blood vessels. And what is it's going to cause is vasoconstriction, and that's going to help shrink the swollen membranes, and then that's going to then lead to a decrease in the nasal drainage. So this medication, the sympathomimetics, they are also going to be effective in treating the congestion that is associated with the allergic rhinitis. We can also use sympathomimetics when we have a patient that has sinusitis or a sinus infection. We can also see it being used for colds. And again, it's going to work on treating that nasal congestion. You've seen this picture before, and here you can see we're working on the alpha-1 receptors, we're mimicking, we're stimulating it. So we're working directly on the nasal alpha-1 receptors, right on those blood vessels, in order to cause vasoconstriction, so we can stop that increased blood flow in order to stop that nasal congestion that the patient is experiencing. For allergic rhinitis, the main reason we're using the sympathomimetics is to relieve that nasal congestion. When it comes to some of the examples here, remember sympathetic nervous system, epinephrine, norepinephrine. Well, if you look at the examples listed here, the end we see ephedrine or ephrin. So now you can think of, oh yeah, these are the sympathomimetics. These are going to be working on that alpha 1 in order to help relieve that nasal congestion. The sympathomimetics that we're using for allergic rhinitis can be administered either intranasally or they can be administered orally. When it comes to the intranasal medications, the vasoconstriction that is happening in those blood vessels, it's really going to be rapid and intense because we're giving the medication directly to where we want it to start working. Well, then it can lead to a side effect. If the patient uses the sympathomimetic too long, it can actually lead to what's called rebound congestion, where now the congestion is happening all over again, but now it's a side effect of the medication. So the medication, we would want to limit the time frame that they are using to only 3 to 5 consecutive days. Therefore, they really should only be using the sympathomimetic during that worst time when they're experiencing the worst signs and symptoms of the allergic rhinitis. And again, we're just working on the signs and symptoms of allergic rhinitis. Oral administration, it is going to take longer for us to see a therapeutic response. Why? Because it has to be absorbed through the stomach to get to the bloodstream. And then, of course, we tend to see more side effects because the medication's now more so getting into systemic circulation. So now we're seeing systemic side effects. They are more likely with the oral administration. Like I already mentioned, the most common adverse effect that we see, especially with the intranasal medication, is going to be rebound congestion, where we have a patient experiencing now a side effect that actually reverts back, and now they're having the same sign and symptom of allergic rhinitis, and now it's being caused from the medication. So the rebound congestion is a side effect. We don't want it to happen. Therefore, we want the patient to limit the use of using the sympathomimetics to only 3 to 5 consecutive days. Another common side effect, especially with the PO medication or the oral medications, is going to be central nervous system stimulation. That is going to be our most common adverse effect of the oral medications. And we'll talk more about this on the next slide. Sympathomimetics are going to be stimulating the sympathetic nervous system. So we can see other body systems that are being affected when we are giving a medication where we're intending to help relieve that nasal congestion, but now we're opening and triggering up other body systems, such as the cardiovascular system. So what's happening if we're triggering sympathetic nervous system? Remember, we are going to be seeing vasoconstriction happening, and then we're going to see increase in blood pressure, increase in heart rate, because we're running from that scary monster. Typically, this isn't a complication that we will see with our patients who have a healthy body, where they have a healthy heart. We don't typically see a problem with giving the sympathomimetics. But if we have a patient that is already experiencing hypertension, they have that chronic disorder, or they have coronary artery disease, giving these sympathomimetics for allergic rhinitis can actually lead to further complications with their chronic condition. So cardiovascular effects is generally not a problem with our healthy patients, but we really shouldn't be giving the sympathomimetics to our patient that has a chronic disorder, especially that cardiovascular disorder. When it comes to this type of adverse effect, remember, It's more likely if we're giving the PO medication because it's getting through systemic circulation, we're seeing more body systems being affected. Sympathomimetics, again, we're triggering the sympathetic nervous system. And when we're running from that scary monster, we want to really be able to focus and be able to get away from that scary situation. Well, triggering sympathetic nervous system, it is going to do that. Well, when we're given a medication that's mimicking it, it can also cause this central nervous system stimulation. Uh, then it can lead to our patients where they may end up abusing the medication. More common, we're seeing abuse of these medications with the pseudoephedrine or the ephedrine. And again, it's due to that central nervous system stimulation. People are getting a high from the medications and their euphoric feeling, it is very similar to using amphetamines. When it comes to the pseudoephedrine and ephedrine, these are medications that are over-the-counter products, but these medications then can be used and readily converted to methamphetamines. And methamphetamines, this is illegal medications or illegal drugs that are being manufactured on the streets. So I mentioned that these medications, they can be purchased over the counter. They used to be readily available. You used to be able to go to any pharmacy and you could just go right to the shelf and pick up these medications. Well, because of the epidemic of drug use in our country or drug abuse in our country, what happened back in 2005, we actually had some changes to the laws where we have a Combat Methamphetamine Epidemic Act of 2005. Well, what did this change to the law do? Well, it actually now made it so the pharmacies are required to keep pseudoephedrine and ephedrine back behind the counter. When it comes to getting these medications for allergic rhinitis, again, you can purchase these medications over the counter, but you can't just go up to the shelf. Now you have to go up to the pharmacy, to the where you get prescriptions filled. You have to specifically ask for these medications. They're kept back with the prescription drugs. And what you'll have to do is you'll have to show your driver's license, and they actually keep track of how much of this medication that you're purchasing in a month's time. So individuals can only purchase no more than 9 grams per month or 3.6 grams of these medications per day. We are really keeping a close eye on these medications. And again, it's because on the streets, they can use these medications to manufacture and make methamphetamines. We talked about how glucocorticoids are going to relieve all the signs and symptoms of allergic rhinitis. We also talked about how antihistamines are a first line treatment also used in treating allergic rhinitis. The problem with the antihistamines, they don't relieve the nasal congestion. So in order to help treat all of the signs and symptoms without using a steroid, we could use a sympathomimetic and an antihistamine combination agent. So it's taking the two different classes of medications, combining them together into one pill in order to treat all signs and symptoms of allergic rhinitis. We do have combination agents where it is now going to have the sympathomimetic, such as pseudoephedrine, mixed with an antihistamine, uh, working on the allergies, and they're all going to be put together into one pill form. Because it has the sympathomimetic added to the antihistamine, you can't purchase these directly off the shelf at the pharmacy. They are still over the counter, but because the sympathomimetic is added to the antihistamine, these combination agents also have to be purchased by going up to the pharmacist and requesting the medication It's going to be kept back where the prescription medications are kept. And again, they're going to keep track of how much you are purchasing. And it all has to do with that sympathomimetic agent that is added to that medication. But again, having these combination products, it's now one pill. The patient's getting all the medications necessary to treat all the signs and symptoms of allergic rhinitis. But remember, if they're using this medication, because it's the sympathomimetic, they should still only use it for 3 to 5 days because it could lead to that rebound congestion. It should not be a long-term use. If they're using the combination product and they're already taking an antihistamine such as Claritin on a daily basis, if they're going to use the combo product for 3 to 5 days, they now need to remember to not take their separate antihistamine. If they're adding it and it's all going to be in this one pill form, we just don't want them to be taking too much antihistamine. They need to remember to stop their antihistamine while they're taking the combo product. Moving on, let's talk about another upper respiratory condition that our patient may experience. And in this case, it's going to be an upper respiratory infection. And we're going to talk about the common cold. The common cold is going to be caused by the rhinovirus. Oh my. So now you got to think about, what do you already know about viruses? When it comes to the rhinovirus, there's a lot of different strains of the rhinovirus. There's hundreds of different strains. Viruses very virulent, where they are going to be able to replicate and create new strains. So that's why we're seeing so many different strains. When it comes to signs and symptoms of the common cold that's caused by the rhinovirus, what are these patients experiencing? Well, they're experiencing a cough, they're experiencing a runny nose, they're experiencing nasal congestion, and they may also be feeling that general malaise where they're just not feeling well. So now when you look at these different signs and symptoms, they're very much the same as the allergic rhinitis signs and symptoms. Because this is a virus, we can only treat the signs and symptoms. We can't treat the virus itself. Therefore, a lot of the same products we've used for allergic rhinitis, now we can also use for the common cold. But again, it's just working on the symptoms. It's not working on the rhinovirus itself. This slide got a little messed up, but I think we can manage to get through it. Histamines, when it comes to allergic rhinitis, we know that the inflammatory process is being triggered, so we are seeing histamines being released. When it comes to the common cold, because it's caused by the rhinovirus, we are not seeing the release of histamine, because remember, histamine being released, it's going to require that presence of the IgE antibodies. And we're not seeing that here with the rhinovirus. This is not an allergic response. We still use antihistamines to treat the common cold, but again, we're treating the symptoms of the common cold. So antihistamines, they're really not valuable in treating the common cold, except for giving that benefit of that sedation. Like I already mentioned, we will use antihistamines in treatment of the common cold, but again, it's treating the symptoms of the common cold. When we're using antihistamines in this case, not working at all to block the histamine in order to stop the inflammatory response. We're not having that happen with the common cold. The rhinovirus is not leading to that immune response. So why would we use the antihistamines? Well, think about your patient. They have a runny nose, they're coughing, they don't feel well. We know that sleep is beneficial. Again, sleep is going to help the body to heal. So if we can help our patients to sleep while they have the common cold, overall, it's going to be beneficial to just help their body healing. The antihistamine, it's not useful in combating the rhinovirus. The greatest use for using it for the common cold is that the symptoms of just causing them where they're just not able to rest like they should be. Other common groups of drugs that we use for the cold is going to be, again, just working on those symptoms. So we can use decongestants to help relieve that nasal congestion. If they're experiencing a lot of coughing symptoms, we can use antitussives. And then if they have a lot of mucus being built up, we can use expectorants or mucolytics. And we're going to talk more about these different groups of medications. Our patient with the common cold, they're experiencing nasal congestion. What medications can we use as a decongestant? Well, sympathomimetics can also be used for the common cold. In this case, it's just helping with that symptom, that complication that they're experiencing with the common cold. So remember, how do they work? Well, it's causing vasoconstriction of those blood vessels directly in the nasal passage in order to decrease that nasal drainage. I'm not going to go into too much more detail because we've just talked about this when we talked about allergic rhinitis. So again, it's the same medications, but now we can use it for another condition. And in this case, we can use it for the common cold. So what are some of those side effects with the sympathomimetics? Well, again, that rebound congestion can happen. They should limit the amount of time taking these medications to no more than 3 to 5 days consecutively. If they're taking oral medications, the oral decongestants, we can see central nervous system stimulation. And then, of course, they could have cardiovascular effects. Not usually a problem for our healthy patient, but our patient that has hypertension or any other coronary artery disease complication, they really shouldn't be using the sympathomimetics. Our patients who are experiencing the common cold typically are having a cough as one of their symptoms of the cold. Well, I don't know about you, but I've had a cough in the past, and it's just so irritating and annoying to myself. So can you imagine how annoyed our patients can be if they're having the cold where they're having these signs and symptoms? So the good thing is we do have medications to help work directly on the control center of that cough, which is in the medulla, and it's going to help suppress that cough. And these are going to be called antitussives. But remember, the cough is not necessarily a bad thing. The cough, really, what is it for? Why does our body do this? Well, it's the body trying to be protective, and it's a protective way to help clear those airways of any secretions. So the cough is the body's natural ability to help fight infection. Why would we give an antitussive or a cough suppressant? Well, if the body is having a cough that is non-productive, where it's not an infection that's leading to the body trying to push that bacteria out of the body. So a cough that's non-productive, it's okay to use the antitussives to suppress that cough. Another time it's okay to give antitussives. Again, if our patient is really having difficulty sleeping because of the cough, now we can give the antitussive in order to promote sleep so the patient can rest and get back to healing with sleeping. We do have two types of antitussives that we can use for our patients with the common cold to help suppress that cough symptom. We do have non-opioids, and then we have opioids. And they are going to work a little bit different in the body, but ultimately the goal is to help stop that cough. Dextromethorphan is a non-opioid antitussive. This is going to be the most frequently used antitussive. One of the reasons being is that it's available over the counter. So if our patient is experiencing a cough, they can go to the pharmacy and they can purchase this medication to help suppress that cough. And they can do this all without a prescription. If the over-the-counter medication does not work, there are higher doses that are available by prescription, but remember then they would have to go see their doctor regarding their cold. Why is dextromethorphan used more frequently? Again, over the counter is one of the reasons. Another reason is it works very well as a cough suppressant. How exactly it works is it is chemically similar to the opioids, and it does work as effectively as codeine to suppress the coughs. When it comes to using this medication, if the patient is using the recommended doses, it's not going to produce the opioid-like euphoria or any physical dependence. But if the patient takes the medication at high doses, it can produce euphoria and it may be abused. We are seeing new research that's coming out where I know your drug guide says that the dextromethorphan, it doesn't work as an analgesic, but the new research is showing that we are seeing a minimal analgesic effect when our patient is using the dextromethorphan. And remember, analgesia is going to be working on pain. What we're also seeing in this new research is when combining dextromethorphan with morphine, we're actually seeing a synergistic effect where they're getting better pain relief using the dextromethorphan with morphine. So new research coming out, we might see some changes with this in the near future with possibly a combo product of morphine with dextromethorphan to work on pain. Tessalon is another medication that is a cough suppressant or an antitussive. How exactly does Tessalon work? Well, it is going to be chemically related to the local anesthetic tetracaine. So anesthesia, you got to think of numbing. Well, Tessalon comes in PO form. It comes in what's called pearls, where they're very teeny tiny and they look like little pearls, but they actually will work by anesthetizing or numbing the stretch receptors in the lung in order to suppress the cough reflex. So they do work very well on suppressing the cough reflex. In this case, though, our patients may not use this as often because these are available by prescription only. A side effect that can happen is if the patient would happen to chew these pearls, the drug can actually cause numbing of the mouth and the pharynx, which can then lead to kind of a panic of where they feel like they can't breathe, they can't catch their breath just because that area is numb. So we would definitely teach the patients not to chew on these pearls. They should just swallow these PO medications. Opioids can also be useful as an antitussive. Examples of these opioids used for this would be codeine and hydrocodone. Remember, opioids are typically used as a pain reliever. In this case, we're using it to suppress the cough. Since we're using it for a different reason, the dose does not need to be nearly as high. The dose for suppressing the cough is only about 1/10 the dose necessary for pain relief. So since we're using such a low dose, we aren't seeing these medications be as causing dependency. So the schedule of the drug changes then. So the class or the schedule would be a schedule 5 when it comes to codeine being used for cough, whereas if we're using codeine for pain, it then becomes a schedule 2 drug. So When it comes to being a lower schedule, like I said, minimal potential for dependency. But of course, if they would overdose using this medication, it can result in respiratory depression. That would be our main adverse effect that could possibly happen. So, of course, educate that they should be taking the medication as prescribed and not taking too much of it. We're still talking about treating the symptoms of the common cold. We've already talked about using the sympathomimetics in order to treat the nasal congestion that goes along with the cold. We've talked about using the antitussive to treat the cough symptom of the cold. And now let's talk about using an expectorant or a mucolytic in order to help clear up the mucus that the patient may be experiencing, that buildup of mucus in their upper respiratory system. So an expectorant, how exactly does it work? It will actually increase bronchial fluid and secretions. Well, what in the world? Why would we want to increase this? Well, we're actually then going to thin out the mucus buildup, so it's going to reduce the thickness and viscosity of the bronchial secretions. It's going to loosen that mucus in order to mobilize that mucus so it can be expectorated or coughed out. Remember, hydration is going to be the best expectorant, so we would want to make sure our patient is taking plenty of fluids while they are also using a medication such as an expectorant in order to help push those mucus secretions out of the body. Guaifenesin is a good example of an expectorant that can be used for the common cold. It is going to be available over the counter, and it's going to be the most effective over the counter expectorant. You may not have heard of guaifenesin before, but you probably have heard of the trade names for guaifenesin. Have you heard of Robitussin? Have you heard of Mucinex? Common commercials that we are seeing. That little mucus guy there. I've seen so many Mucinex commercials that have that mucus guy. And what are we trying to do with this medication? Well, we're trying to get rid of the mucus. We're using the expectorant, the guaifenesin, in order to liquefy those secretions so the patient can cough those out. We've talked about the expectorant to help clear out that mucus. Let's talk about a mucolytic. It's really working very similar to the expectorant, the guaifenesin. So mucolytic, some examples would be hypertonic saline solution or acetylcysteine or mucomist. These are working very similar, like I said, to the expectorants. They are also going to help loosen those thick bronchial secretions, help to break down the chemical structure of those mucus molecules in order to help that mucus to become thinner so our patient can cough that mucus out, clear up those airways so they can breathe better. So the hypertonic saline solution, this can be administered by nebulizer. And again, it's just loosening those secretions, helping the patient to feel better from those signs and symptoms of the common cold. Acetylcysteine or mucomist, this is going to be administered via inhaler. The one thing that stands out with this medication is that it stinks. It smells like rotten eggs. I don't know if you've ever smelled rotten eggs, but it's a very noxious odor. This medication is not available over the counter, so the patient would have to go to the doctor to get a prescription. It does work very well, though, to help thin those thick bronchial secretions. The other thing with mucomist, you'll hear about this in the future. It is also the antidote for acetaminophen. Yes, I said acetaminophen or Tylenol. Patients can overdose on acetaminophen. So we can use mucomist in order to combat that overdose. So it is an antidote for acetaminophen. Interesting, right? When it comes to the different medications that we talked about for treating the common cold, again, we're treating the symptoms. Those drugs, those medications, if we use them individually, they're only working on those individual signs and symptoms. So in order to treat all the signs and symptoms of a cold, we would have to use several of those different products. The good thing is there are some combination cold remedy products that are also available, very similar to our allergic rhinitis combination medications. So we're taking two different classes or three different classes of medications, combining them so they're now into one pill form or liquid form so our patient can be relieved of all their signs and symptoms of the cold. So we can see combination cold remedies such as nasal decongestion, the antitussive, the analgesic, antihistamine. We can also see caffeine added into these products, and we'll talk a little bit more of these different combo products. Have you seen this product before? Tylenol PM. This is going to help relieve signs and symptoms of the common cold. It is available over the counter. It's going to be two different products as a combo medication into one pill form. This combo product is actually a combination of acetaminophen and Benadryl. So when we think of those two different types of medication, what would the therapeutic effect be of this combo product? Well, the acetaminophen is going to work to relieve pain, and the Benadryl or the diphenhydramine is going to help give that benefit of promoting sleep. So again, it's treating the symptoms of the common cold. Here you see another combo product that we can use to treat the common cold. If you look at the medication, look at that label, what medication combination do you think might be in this medication? So you're seeing it's Robitussin. It's telling you it's going to be used for head and chest congestion. It's going to have an expectorant and a nasal decongestion in there. So if it's relieving stuffy nose and chest congestion, in this case, this product contains phenylephrine, which is going to be your nasal decongestion, and it also has that guaifenesin in that combo product, and that's going to be your expectorant. So again, combo product treating the signs and symptoms of a common cold. Well, we finally made it through the upper respiratory conditions. Now let's talk about medications that can be used for lower respiratory tract disorders. And these medications can be used for acute and chronic lower respiratory tract disorders. We are just going to talk about asthma, like I said, but some other lower respiratory disorders that we can use the same medications for would include chronic bronchitis, emphysema, pneumonia, or COPD. COPD, they did recently change the name. They're now calling it chronic lower respiratory disease, but in a lot of the literature, I'm still seeing it being referred to as COPD. Like I said, I'm only going to talk about asthma in this class, but again, the same medications can be used for several lower respiratory conditions. When it comes to treating these lower respiratory conditions, we do need to think about what's happening in the pathophysiology, because most of the time when we're treating the condition, we're treating somewhere in that pathophysiology in order to relieve the signs and symptoms of the condition. Asthma, one of the reasons I'm going to talk about this one is because it's a very chronic or common chronic disorder that we are seeing in our country. It is affecting more than 26 million people. That's the current statistic that I have. Again, it's a chronic condition, and it's actually an inflammatory disorder of the airway. And again, it's that immune response that's leading to airway inflammation, which then leads to the signs and symptoms of asthma. A little bit more on asthma. What exactly is happening in the body? Well, what we see with asthma is we see inflammation, and this is specifically to the lower respiratory system. Asthma is inflammation, but it's not normal inflammation. This is a disorder, and it's a chronic inflammatory airway disorder where the airway is having hyper responsiveness, where we're seeing recurrent episodes of signs and symptoms of wheezing, coughing, tightness in the chest, and then shortness of breath. Why exactly is this happening? Well, our patient, it's typically triggered by an allergen, and here you can see the common allergen or the common asthma triggers. But the biggest thing is now we have bronchoconstriction happening, and oxygenation is going to be impaired. So we are going to treat the pathophysiology of this condition in order to relieve the signs and symptoms so our patient can breathe better. I mentioned that the asthma is going to be an inflammatory disorder. Are they constantly going to have bronchoconstriction? No, it's going to be when they become exposed to the allergen or they become exposed to whatever triggers their asthma. And now they end up having what's called an asthma attack. So this is an it's a chronic disorder where it has acute attacks. So during the asthma attack now, the patient is experiencing that bronchospasm. They're also having the inflammation, which is then leading to constricted bronchi. The inflammation is causing the increased mucus secretion, and it's specifically there in the airways, which then leads to edema in the airways. So again, the biggest issue here is oxygenation. They're not able to get the oxygen in, and now the oxygen is affected. So we need to make sure we clear out those airways, open the airways up in order for the patient to be able to breathe better. So when it comes to medicating the patients, the drugs that we are going to use, they're going to be focused on two different characteristics. We're going to be using bronchodilators, and then we're also going to be using anti-inflammatories. And again, it all goes back to the pathophysiology of what is happening in these acute attacks, which is a chronic disorder that these patients have. So we're going to use bronchodilators to treat asthma, and we're also going to use anti-inflammatories. The bronchodilators, we've talked about some of these already. We've talked about beta-2 adrenergic agonists. Methylxanthines can also be used, and then anticholinergics. And again, they're all working right on the bronchioles in order to dilate and open up those airways. And then because there is inflammation happening with asthma, we can also use anti-inflammatory agents. Here we talk about glucocorticoids again, we talk about the cromolyn again, and leukotriene modifiers. We can also use IgE antagonists. So lots of different medications to treat asthma. One lower respiratory condition, we are going to see these same medications being used in other chronic lower respiratory disorders. So remember, these medications can also be used to treat our patient with bronchitis, to treat our patient with COPD, emphysema. So different combinations will be used. Again, you'll see these medications for other conditions. Now we got to think back to the sympathetic and parasympathetic nervous system. Remember, these two systems, they are going to be affecting the bronchial smooth muscles in opposite ways. Parasympathetic nervous system, remember, it's releasing acetylcholine, and the acetylcholine is then causing bronchoconstriction. Sympathetic nervous system is doing the opposite. This is releasing norepinephrine, and that is going to cause bronchodilation. Now, when we think of pathophysiology of asthma, we're thinking, asthma is leading to bronchial constriction. Therefore, we want to give a medication that's going to lead to bronchodilation. So again, we can use a sympathomimetic or a bronchodilator. Let's talk about a bronchodilator agent that we can use. We can use a beta adrenergic agonist, which is going to be a sympathomimetic, and it's going to be working directly on the beta 2 receptor. We've talked about beta 2 before. When we think about beta 2, remember there's two lungs, so we know if we're stimulating beta 2, we're going to help cause bronchodilation when using a sympathomimetic. So working directly on the bronchial smooth muscle. In this case, though, it's not working on the inflammation part of asthma. It's just working on the bronchoconstriction to help cause bronchodilation so our patient can breathe better when they're having an asthma attack. Because bronchodilators don't work on the inflammation part of asthma, the patient should also be prescribed at least inhaled glucocorticoids or something else to work on that inflammation. A little bit more about the beta 2 agonist. We do have medications that are selective directly for the beta 2 receptor. Then this is really going to be our treatment of choice for asthma in order to dilate those bronchioles. We don't see a whole lot of side effects, but remember there are potential side effects if we would be stimulating both beta 1 and beta 2. The whole purpose of giving the beta 2 medication for asthma is to cause bronchodilation, but if we would be stimulating beta 2, we would also see cardiovascular effects. So it's going to be better if we have a selective medication working directly on beta 2. When it comes to beta agonists, they can either be administered via inhaler, they can be administered via nebulizer, or we do have oral forms. When it comes to the inhaled medications, the side effects generally are minimal because they're going directly to the site where we want to see the therapeutic response. If we're giving a PO medication, we do tend to see more systemic side effects just because it is going to be, the medication is going to be going all across the body, triggering more organs to be affected with those side effects. When it comes to the beta 2 agonists that we have available, we do have different forms that are available. We have short acting forms, and then we also have long acting. When it comes to these different types, they are going to be used for different reasons. The short acting ones are going to be given via inhaler, and they're going to be used as a quick relief to relieve that attack, the asthma attack that's currently happening. It is going to be taken PRN because they're not going to be constantly having an asthma attack. This is going to be taken when they are having an asthma attack in order to relieve that asthma attack. There are going to be long acting medications that are beta 2 agonists. And being that it's long acting, it's going to be used to prevent the asthma attack. It's not going to be used to stop the current attack. So this would be given on a daily basis in order to minimize and prevent the patient from having an asthma attack from one of their triggers. And again, we are going to be using these medications in conjunction with an inhaled glucocorticoid, where the glucocorticoid is going to work on the inflammatory process that's happening. Notice that these medications end in terol. These are the beta 2 agonists. When it comes to the short-acting inhaled beta 2 agonists for an asthma attack, if their trigger is exercise that's inducing an asthma attack, it can also be taken prior to them exercising. in order to prevent that asthma attack. But most of the time, it's going to be used once they are having an asthma attack. Methylxanthines are also going to be used for our patients that have asthma. And why would these be given? Well, these medications will cause bronchodilation. They also will lead to central nervous system excitation, vasodilation, cardiac stimulation, and can also promote diuresis. In this case, why are we using it? Well, it's for that bronchodilation effect. When it comes to methylxanthines, what medications fall under this class? Well, theophylline, aminophylline, and caffeine also falls under methylxanthines. We will see theophylline being used for our asthmatic patients. And why would we use it? Well, the medication is going to work to relax the smooth muscles of the bronchi, the bronchioles, and the pulmonary blood vessels. And in this case, the main area we want to be affected is going to be the bronchi in order to dilate those bronchioles in order to help the patient to breathe better. When it comes to theophylline, it does have a narrow therapeutic range. Therefore, we would have to monitor the theophylline levels. Primarily, the medication is going to be administered PO. Why? Because it's not going to be therapeutic if we give it via inhaler. So this would be a medication that is going to be used prophylactically in order to prevent an asthma attack from occurring. Aminophylline is another medication that can be used for asthma. More so, we're seeing it if our patient is having an asthma exacerbation where their usual medications are not working effectively. So we do have aminophylline that we can use. In this case, though, the patient would have to be hospitalized because this medication can only be given via IV, and it's going to be administered very slowly IV. Why slowly? Well, if we administer it too rapidly, it can actually produce severe hypotension. It can lead to death. It's also incompatible with many other medications. So if you ever have to give this medication, be very, very careful. It is going to be a theophylline salt. The benefit is going to be bronchodilation. So that's why we would see it being used. Another type of medication that can be used for our lower respiratory conditions would be an anticholinergic. And remember, anticholinergic is going to be blocking the parasympathetic nervous system, essentially then going to be stimulating sympathetic nervous system, thus causing bronchodilation. We used to see atropine being used very widely in treating asthma. We're not seeing it being used too often. Why? Because we're seeing too many side effects when the patient's taking an anticholinergic. In this case, these medications would be used to prevent an asthma attack from occurring. Other anticholinergic agents that are available to prevent asthma attacks are going to be Atrovent, Spirivia. You may have heard of these different medications. These medications are going to be administered via inhalation. So we do have inhalers for these. They are going to work very well in order to, again, help prevent the asthma attack. Spirivia is also approved for COPD. When it comes to using Spirivia or Atrovent for asthma, it's actually off-label use. They are approved by the FDA for COPD, but we're seeing the benefit of bronchodilation. So you are going to see some patients that have asthma that are prescribed these medications. Now that we've talked about the bronchodilators used for our lower respiratory disorders, let's talk about the anti-inflammatory medications that should also be used in combination with the bronchodilators, especially for our asthmatic patients. Here again, we're going to see glucocorticoids being used for our asthmatic patients, and these really should be used as a cornerstone for asthma therapy for most of our patients. Very, very effective medications as anti-asthma medications. So they're helping to prevent the asthma attacks. When it comes to glucocorticoids for asthma, it's going to be given via an inhalation to prevent our asthma attacks. So long-term prophylaxis using those inhaled glucocorticoids. We can also see oral or PO glucocorticoids being used for asthma, more so for our asthma exacerbation. So short-term management for the acute asthma exacerbation. Long-term use, it's going to be our inhaled. Short-term for exacerbation is going to be the oral. A little bit more about the glucocorticoids. These are going to be inhaled steroids in order to help prevent the patient from having an asthma attack. And remember, it's working on the inflammation part of asthma. Inhaled steroids are not going to be helpful in treating the acute asthma attack. Again, we're using these to prevent the asthma attack. It actually takes a little bit of time for the medication to reach that therapeutic level with the inhaled steroids. So it can take 1 to 4 weeks for us to be seeing the benefit of using these medications for asthma. When it comes to the side effects, we tend to see local side effects with those inhaled glucocorticoids. Some of these local side effects would be throat irritation, hoarseness, dry mouth, cough. There are some things we can do to help prevent these side effects, especially since they're local side effects. Being that it's caused from an inhaled medication, well, let's get rid of the medication off of those areas. So our patient, we want the medication to get to the lungs in order to treat the inflammation in the lungs, but we can get the medication off the area of the throat, the mouth. So advise the patient to rinse their mouth after they use that steroid inhaler. That will help prevent those other local side effects that can occur. Examples of the glucocorticoids that we have available to treat our lower respiratory conditions. These are going to be ending in one or "-one". So again, we have glucocorticoids for asthma, working on the inflammation. We have some available as inhaled form, some are oral form, and another one is going to be an injectable form. And you can see the different examples that we have. We talked about glucocorticoids being used for allergic rhinitis, and when they're using it for allergic rhinitis, we don't tend to see adverse side effects because they're using a relatively low dose and they're only using it for a short period of time. When it comes to using glucocorticoids for asthma, they are going to be using these medications for a long period of time. It's going to be daily use of this medication. Therefore, we do see side effects. So long-term use side effects of glucocorticoids include adrenal effects, where we see cortisol suppression, and now the body can experience a mimicking of what's called Cushing's syndrome. So our patients' long-term steroid use can lead to fluid retention, hyperglycemia, hypokalemia, immunosuppression, wasted extremities, thin skin, bruising, muscle wasting, and then a buffalo hump. When it comes to the steroids, you may hear patients gaining weight. Well, it's because they're retaining the fluid, they're holding on to the sodium, they're pushing potassium off the body. Well, now they're holding on to extra fluid. Like I said, it leads to edema. We can see weight gain. Our patients may not like the fact that they're experiencing the weight gain, these side effects of the steroids, but remember the benefit is we're treating the inflammation that's related to the asthma. So we need to talk to them about taking their medication on a regular basis in order to help with that inflammation to prevent the asthma attack. Our patient with asthma, they are going to be prescribed a bronchodilator and a glucocorticoid. When it comes to being prescribed an Atrovent inhaler and a glucocorticoid inhaler, they're going to have two different inhalers. When it comes to patient teaching, which one should the patient use first? Is it really going to matter? Well, it actually does matter. They really should take the bronchodilator first in order to open up those airways. And then once those airways are open, then they take the anti-inflammatory. This is going to allow the anti-inflammatory more is going to get into their lungs in order to treat that inflammation because we've opened up the airways first using that bronchodilator. We've talked about cromolone already. Now we're going to be using it for our patient that has asthma. Cromolone, remember, it is a mast cell stabilizer. It's working directly on that mast cell in order to prevent the release of those inflammatory mediators. So why would we use it for asthma? Well, it's going to be prophylactically in order to prevent asthma attack. It's not going to be effective in treating those acute asthma attacks. Cromolone is very safe. We don't see a whole lot of side effects, but remember, this is used to prevent. So this is going to be a medication they have to take on a daily basis. And in this case, it can take several weeks after administration for a maximum therapeutic benefit. So again, they need to take the medication daily. They need to use it regularly in order for us to see the therapeutic response. Leukotriene modifiers are also going to be used for asthma. In this case, it's not going to be useful for the acute attack. It's going to be useful in helping to prevent an asthma attack. And how is it working? Well, it's going to be used to reduce inflammation, and it's also going to be useful in mediating the inflammatory response. Remember, leukotrienes also promote bronchoconstriction. So if we can block that, we can help with the bronchodilation. So here's a medication that works not only to bronchodilate, but it also works on that inflammation. So the two different parts of the asthma and what's happening with the pathophysiology. Here are some examples of the leukotriene modifiers. And remember, these are going to be useful in helping to prevent the asthma attacks from occurring, working not only on the inflammation part, but also working on helping to keep those airways open, bronchodilating. So most of our patients for long-term use are going to be prescribed one of these medications. They do work very well for asthma. When it comes to treating asthma or these lower respiratory disorders, we do have a lot of variety in the different medications that are available to treat these conditions. How in the world does the doctor know which medication to use? Well, remember, when it comes to these disorders, especially asthma, we want to make sure the airways are staying open, so a bronchodilator, and then we also need to think there's inflammation going on there too, so we need some sort of anti-inflammatory. Really, it comes down to which medication is working the best for our patients, helping to treat the condition itself, and then also to make sure they're experiencing minimal side effects of these medications. So if they were on a long-term steroid, they're gaining a lot of weight, they're having a lot of signs and symptoms, the doctor may switch them to a different medication. Um, Other choices that we do have, there are some combination products where it's now combined into one product, so they're not necessarily needing to take several medications in order to treat one condition. We do have Advair, which is a combination product. In this case, the combination is going to be a corticosteroid and a bronchodilator all in one medication. It makes it easier for administration for these patients. They may not forget to take all these different medications if it's all combined into one product. Another example would be Symbicort, and this combination again is a corticosteroid and a bronchodilator, and it's all in one form where they're taking one medication. So it makes it, like I said, easier for administration for the patients. The next few slides are NCLEX questions just to help you get a little bit of practice with NCLEX questions related to respiratory conditions.